Welcome to this lecture on the muscles of the foot, ankle, and lower leg. We're going to treat muscle anatomy as a clinical tool, not just as a list of origins, insertions, actions, and nerves. Each compartment helps explain movement, gait, palpation, resisted testing, nerve screening, and rehab decisions. As we move through the lecture, keep connecting structure to function. The anterior compartment clears the foot during gait. The lateral compartment controls eversion and helps protect against inversion stress. The superficial posterior compartment powers plantar flexion and push-off. The deep posterior compartment supports the arch and toe flexion. If you can connect each compartment to its action and nerve supply, the anatomy becomes much easier to use clinically. These objectives are the roadmap. By the end, you should be able to identify the major lower leg compartments, name the key muscles in each group, and connect those muscles to actions at the ankle, foot, and toes. You should also recognize the basic nerve patterns for the deep fibular, superficial fibular, and tibial nerves. The bigger goal is clinical application. Instead of only asking what a muscle does, ask what the athlete would struggle with if that muscle were weak, painful, or neurologically impaired. Study this region by grouping information first by compartment, then by action, then by nerve. Once that organization is clear, add clinical patterns such as tendinopathy, nerve injury, ankle instability, and compartment syndrome. Use this figure to build a mental map of the lower leg. The region is organized into compartments with predictable actions, nerve supplies, and symptom patterns. That organization helps you localize problems during an exam. Weakness with dorsiflexion and toe extension points toward the anterior compartment and deep fibular nerve. Pain with resisted eversion points toward the lateral compartment and fibularis tendons. Difficulty with push-off points toward the calf complex, Achilles tendon, or tibial nerve function. Medial arch pain may involve the deep posterior compartment, especially tibialis posterior. Keep returning to this map as we move through the lecture, because every muscle we discuss fits into this larger clinical framework. This table gives a quick overview of the four major compartments. The anterior compartment includes tibialis anterior, extensor hallucis longus, extensor digitorum longus, and fibularis tertius. Its main roles are dorsiflexion and toe extension, with the deep fibular nerve as the key nerve. The lateral compartment includes fibularis longus and brevis. These muscles evert the foot and support the lateral ankle through the superficial fibular nerve. The superficial posterior compartment contains gastrocnemius, soleus, and plantaris, which create powerful plantar flexion through the tibial nerve. The deep posterior compartment includes tibialis posterior, flexor hallucis longus, and flexor digitorum longus. These muscles support plantar flexion, inversion, toe flexion, and arch control. The clinical takeaway is simple. Link compartment, action, and nerve together. This slide translates anatomy into movement. Dorsiflexion is primarily an anterior compartment action, especially through tibialis anterior, and it is essential for foot clearance. Plantar flexion is primarily a posterior compartment action, especially through gastrocnemius and soleus, and it drives push-off during walking, running, and jumping. Inversion uses tibialis anterior and tibialis posterior together, while eversion is mainly controlled by fibularis longus and brevis. Toe extension comes from extensor hallucis longus and extensor digitorum longus, while toe flexion comes from flexor hallucis longus, flexor digitorum longus, and the intrinsic foot muscles. Clinically, remember this pattern. A weak action suggests nerve involvement or loss of muscle capacity. A painful action suggests muscle or tendon irritation, and sensory loss should make you map the nerve distribution. Now we move into the anterior compartment. This group is responsible for dorsiflexion and toe extension, which makes it essential for gait, foot clearance, and controlled heel strike. Clinically, anterior compartment problems may show up as foot slap after heel contact, reduced toe clearance, difficulty heel walking, or pain along the front of the lower leg. These signs can reflect overuse, tendon irritation, deep fibular nerve involvement, or in urgent cases, compartment syndrome. As we go through the anterior muscles, think about how you would test them. Dorsiflexion, great toe extension, lesser toe extension, and sensation in the deep fibular nerve distribution all help build the clinical picture. The anterior compartment includes tibialis anterior, EHL, EDL, and fibularis tertius. All are supplied by the deep fibular nerve and contribute to dorsiflexion or toe extension. Tibialis anterior inserts on the medial cuneiform and base of the first metatarsal, producing dorsiflexion and inversion. EHL extends the great toe and assists dorsiflexion. EDL extends toes 2 through 5 and assists dorsiflexion. Fibularis tertius assists dorsiflexion and eversion near the fifth metatarsal. To make the table clinically useful, pair each muscle with a resisted test: ankle dorsiflexion and inversion for tibialis anterior, great toe extension for EHL, lesser toe extension for EDL, and dorsiflexion with eversion for fibularis tertius. Tibialis anterior is the primary dorsiflexor and also contributes to inversion. During gait, it controls foot lowering after heel strike and helps lift the foot during swing phase. Weakness may create foot slap, poor toe clearance, or a high stepping gait. Pain may appear as anterior shin discomfort with walking, running, hills, or repeated dorsiflexion demand. Clinically, test tibialis anterior by resisting dorsiflexion and inversion. Compare both sides, observe heel walking, and watch gait quality. If weakness is present, do not stop at manual muscle testing. Screen sensation and consider deep fibular nerve involvement, especially if the athlete reports numbness, tingling, or loss of foot control. EHL, EDL, and fibularis tertius are smaller muscles, but they matter. EHL extends the great toe and helps dorsiflex the ankle. EDL extends toes 2 through 5 and assists dorsiflexion. Fibularis tertius assists dorsiflexion and eversion. These actions are important during gait, foot clearance, and neurologic screening. Great toe extension is especially useful because it gives information about deep fibular nerve function. Weakness or pain with toe extension may suggest anterior compartment overload, extensor tendinopathy, dorsal foot irritation, or nerve-related deficit. In your exam, do not only test ankle dorsiflexion. Test great toe extension, test lesser toe extension, compare side to side, and connect the finding to gait and nerve screening. The lateral compartment contains the fibularis, or peroneal, muscles. These muscles evert the foot and help provide dynamic support against inversion forces at the ankle. This is highly relevant after lateral ankle sprains. It is easy to focus only on the ligaments, but the fibularis tendons may also be painful, weak, irritated, or unstable. Lateral compartment dysfunction can affect cutting, landing, balance, and confidence on uneven surfaces. As we move through this section, think about lateral ankle pain in a broader way. Ask whether symptoms fit a ligament sprain, fibularis tendon involvement, fifth metatarsal injury, nerve irritation, or a combination of these findings. Fibularis longus and fibularis brevis both evert the foot, but their insertions explain different clinical roles. Fibularis longus begins on the proximal lateral fibula and crosses under the foot to insert near the medial cuneiform and base of the first metatarsal. That gives it a role in eversion, weak plantar flexion, transverse arch support, and first ray mechanics. Fibularis brevis originates from the distal lateral fibula and inserts on the base of the fifth metatarsal, making it important for eversion and lateral ankle support. Both are supplied by the superficial fibular nerve. In the exam, palpate along the tendon course, resist eversion, and always check the fifth metatarsal after inversion type injuries. Fibularis tendon pathology often presents as lateral ankle pain, tenderness behind the lateral malleolus, pain near the lateral calcaneus, or symptoms near the fifth metatarsal base. It may follow an ankle sprain, chronic instability, forceful inversion, or repetitive eversion loading. The exam should include resisted eversion, palpation along the tendon course, ankle stability testing, gait or balance observation, and inspection for snapping or subluxation. Keep the differential broad. Tendinopathy, tendon tear, subluxation, fifth metatarsal fracture, and lateral ankle sprain can overlap. The clinical pearl is important. Do not stop at ankle sprain. Check the tendons, check the fifth metatarsal, and screen nerve function when symptoms suggest it. The superficial posterior compartment contains the big plantar flexors that drive propulsion. Gastrocnemius, soleus, and plantaris work together through the Achilles tendon, but they are not identical. Gastrocnemius crosses the knee and ankle, while soleus crosses only the ankle. That difference matters for testing, stretching, symptom interpretation, and rehab. Clinically, this compartment is involved in calf strains, Achilles tendinopathy, plantar flexor weakness, limited ankle dorsiflexion, running load intolerance, and return to sport progression. As we go through this section, pay attention to knee position, calf capacity, Achilles loading, and how plantar flexor function supports sprinting, jumping, deceleration, and repeated running. The superficial posterior muscles are gastrocnemius, soleus, and plantaris. Gastrocnemius originates from the medial and lateral femoral condyles and inserts on the calcaneus through the Achilles tendon. Because it crosses the knee and ankle, it contributes to plantar flexion and knee flexion. Soleus originates from the posterior tibia and fibula and also inserts through the Achilles tendon. It is a major plantar flexor and endurance muscle for posture, walking, and running. Plantaris is small, but symptoms can mimic a calf strain. All are supplied by the tibial nerve. Clinically, separate gastrocnemius and soleus by changing knee position during testing and stretching. To differentiate gastrocnemius and soleus, manipulate knee position. Gastrocnemius is more emphasized when the knee is extended because it crosses the knee. Soleus remains a major plantar flexor when the knee is flexed and is critical for endurance and postural control. This matters when interpreting calf pain, Achilles symptoms, dorsiflexion restriction, or return to running capacity. Compare ankle dorsiflexion with the knee straight and bent. Test calf strength with straight knee and bent knee heel raises. Palpate the muscle-tendon junction and ask where symptoms localize. Calf capacity is central to running, jumping, deceleration, and return to sport progression, so do not only test one quick plantar flexion contraction. The Achilles tendon transmits force from gastrocnemius and soleus to the calcaneus. Because it handles high loads, tendon symptoms often relate to running, jumping, sprinting, hill work, plyometrics, or sudden training increases. Differentiate mid-portion Achilles pain from insertional pain because load and stretching strategies may differ. The exam should include tendon palpation, morning stiffness questions, ankle dorsiflexion, calf strength and endurance, single leg heel raise capacity, and kinetic chain contributors. Watch for rupture red flags, sudden pop, palpable gap, major weakness, positive Thompson test, or inability to plantar flex against gravity. The clinical pearl is that tendon rehab is load management, and suspected rupture requires referral. The deep posterior compartment is important for arch support, toe flexion, and medial ankle function. It includes tibialis posterior, flexor digitorum longus, and flexor hallucis longus, all supplied by the tibial nerve. These muscles are less visible than the calf, but they are clinically important because they connect to medial shin pain, posterior tibialis symptoms, tarsal tunnel considerations, arch collapse, and push-off mechanics. In this region, symptoms may be subtle, so location and resisted testing matter. Think about pain behind the medial malleolus, navicular tenderness, medial arch symptoms, toe flexion pain, and neurologic symptoms into the plantar foot. The deep posterior muscles include tibialis posterior, FDL, and FHL. Tibialis posterior originates from the posterior tibia and fibula and inserts broadly into the navicular, cuneiforms, cuboid, and metatarsal bases. It supports the medial arch and contributes to plantar flexion and inversion. FDL flexes toes 2 through 5 and assists plantar flexion and inversion. FHL flexes the great toe and contributes to push-off, especially in running, jumping, and dance. All three are supplied by the tibial nerve. Clinically, use palpation, resisted inversion, toe flexion testing, heel raise observation, and foot posture assessment to decide whether the deep posterior compartment is contributing to symptoms. Tibialis posterior is a key dynamic supporter of the medial longitudinal arch. Symptoms may appear behind the medial malleolus, along the navicular, or in the medial arch. Dysfunction can contribute to progressive pronation, arch drop, and difficulty with single leg heel raise. In the exam, palpate the tendon course, Assess navicular tenderness, test resisted inversion and plantar flexion, observe heel raise quality, and compare arch behavior side to side. Differentiate this from tarsal tunnel syndrome, deltoid ligament injury, navicular stress injury, and plantar fasciopathy. The clinical pearl is to watch the arch during heel raise. Pain plus weakness matters, and progressive deformity or inability to perform a heel raise warrants referral. FHL and FDL contribute to toe flexion, arch support, and push-off. FHL flexes the great toe and is especially important during propulsion in running, jumping, and dance. FDL flexes toes 2 through 5 and assists plantar flexion and arch control. FHL symptoms may be relevant in posterior ankle pain, great toe push-off pain, sesamoid irritation, and first MTP conditions. Toe flexor testing can help separate deep posterior muscle involvement from plantar fascia or intrinsic foot pain. Clinically, resist great toe flexion, resist toe flexion for digits 2 through 5, observe push-off during gait, compare endurance, and palpate the tendon course when appropriate. The Tom, Dick, and Harry mnemonic organizes structures behind the medial malleolus from anterior to posterior, tibialis posterior, flexor digitorum longus, posterior tibial artery and tibial nerve, and flexor hallucis longus. Use this as an anatomy map, not just a memory trick. Tendons, vessels, and the tibial nerve share space in the medial ankle region. That means swelling, trauma, or tissue irritation can influence multiple structures. Symptoms here may reflect tendon pathology, tarsal tunnel syndrome, vascular concern, or posterior ankle irritation. The key clinical point is that burning, tingling, numbness, or plantar foot paresthesia changes the differential and should prompt neurovascular screening. Nerve supply helps connect anatomy to clinical patterns. Deep fibular nerve involvement may affect dorsiflexion, toe extension, and sensation in the first dorsal web space. Superficial fibular nerve involvement may affect eversion and sensation over the dorsum of the foot or lateral lower leg. Tibial nerve involvement may affect plantar flexion, inversion, toe flexion, and plantar foot sensation. The sural and saphenous nerves are mostly sensory and help explain lateral or medial lower leg symptoms that do not match a muscle pattern. When an athlete has weakness, numbness, tingling, or symptoms that radiate, combine motor testing with sensory mapping instead of treating the issue like a simple muscle strain. A quick nerve screen should be purposeful. For the deep fibular nerve, test dorsiflexion, great toe extension, and sensation in the first dorsal web space. For the superficial fibular nerve, test eversion and sensation over the dorsum of the foot and lateral lower leg. For the tibial nerve, test plantar flexion, inversion, toe flexion, and plantar foot sensation. Sural nerve symptoms may appear along the posterolateral calf or lateral foot, while saphenous nerve symptoms may appear along the medial lower leg or ankle. Compare side to side and document clearly. Progressive weakness, spreading sensory loss, or neurovascular symptoms should change urgency and may require referral. Palpation and resisted testing should be purposeful. Before palpating, know the muscle line, tendon course, and insertion. You are trying to localize tenderness, reproduce symptoms, assess tissue irritability, and compare sides. Resisted testing helps determine whether a contractile tissue becomes painful or weak under load. Pair the resisted action with the suspected muscle, dorsiflexion and inversion for tibialis anterior, eversion for fibularis, plantar flexion for the calf complex, and inversion or arch support for tibialis posterior. If pain is severe, focal bony tenderness is present, fracture is suspected, or symptoms worsen with testing, stop and refer rather than escalating stress. Palpate with purpose, test with purpose, compare bilaterally, and document clearly. Compartment syndrome is where muscle anatomy becomes a safety issue. A fascial compartment has limited space, so rising pressure can compromise perfusion and nerve function. Acute warning signs include severe pain, pain out of proportion, pain with passive stretch, a tense compartment, paresthesia, weakness, and worsening symptoms after trauma or exertion. Anterior compartment involvement can threaten deep fibular nerve function, dorsiflexion, and toe extension. Chronic exertional compartment syndrome usually presents differently, with exertional tightness or pain that predictably increases with activity and improves with rest. Suspected acute compartment syndrome is an emergency referral situation. Do not miss pain out of proportion, passive stretch pain, paresthesia, weakness, a tense compartment, or escalating symptoms. Muscle anatomy should guide rehabilitation design. If dorsiflexors are weak, train controlled dorsiflexion and gait clearance. If fibularis function is impaired after ankle sprain, progress eversion strength, balance, landing control, and cutting. If plantar flexors are involved, gradually restore calf capacity through isometrics, raises, eccentrics, endurance work, and plyometrics. If tibialis posterior or toe flexors are involved, address arch control and push-off tolerance. Progress from bilateral to unilateral, slow to fast, predictable to reactive, and simple to sport-specific. Use symptoms, strength, endurance, movement quality, and sport demand to guide progression. The goal is not just isolated strength, it is durable function under athletic load. Let's apply the anatomy to lateral ankle pain. A basketball athlete steps on another player's foot and develops lateral ankle pain. Pain with resisted eversion and tenderness behind the lateral malleolus should make you consider fibularis tendon involvement. Tenderness near the base of the fifth metatarsal means you must also consider a fifth metatarsal injury, not just a ligament sprain. A safe exam includes inspection, palpation of the lateral ligaments, fibularis tendons and fifth metatarsal, resisted eversion, ankle stability testing when appropriate, neurovascular screening, and functional testing only if safe. Referral is triggered by inability to bear weight, focal bony tenderness, suspected fracture, tendon subluxation, major weakness, neurovascular changes, or an atypical presentation. In this medial arch pain case, a distance runner has pain that worsens late in runs, tenderness behind the medial malleolus and near the navicular, a painful single-leg heel raise, and more arch drop on the symptomatic side. Those findings bring tibialis posterior into the differential because it supports the medial arch and is stressed during repetitive running. Still, do not assume this is only tendon pain. Screen for tarsal tunnel symptoms, such as burning, tingling, numbness, or plantar foot paresthesia. Also consider navicular stress injury and plantar fasciopathy, depending on tenderness and load response. Early management should reduce running load, address footwear and surface, protect painful activity, and begin strengthening only when symptoms allow. The key takeaway is that compartments create order. The anterior compartment dorsiflexes and extends the toes. The lateral compartment everts the foot and supports lateral ankle stability. The posterior compartments plantar flex the toes, support the arch, and contribute to push-off. Nerves help localize deficits. Deep fibular nerve for dorsiflexion, toe extension, and first web space sensation. Superficial fibular nerve for eversion and dorsal foot sensation. Tibial nerve for plantar flexion, inversion, toe flexion, and plantar foot sensation. Function drives rehab. Test the action that matches the suspected muscle, train the action that is weak or painful, and progress toward endurance, speed, and sport-specific demand. These references support the anatomy, examination, and clinical application discussed throughout the lecture. Clinically oriented anatomy sources reinforce muscle location, compartment organization, and neurovascular relationships. Muscle testing references connect structure to palpation and resisted testing. Orthopedic assessment references help place those findings into a broader evaluation framework. As you continue studying, use references to review details that are easy to confuse, such as nerve distributions, tendon pathways, and compartment-specific actions. To close, remember the main framework. Know the compartment, identify the action, screen the nerve, test with purpose, and connect the finding to sport function. That is how lower leg muscle anatomy becomes useful in patient care.